Right, so I know my voice isn't that loud. I'm gonna try to do this not near the mic. Please let me know if you can't hear, okay? So this, this is a difficult thing to put together. And I was just telling Sally, I started this 5 or 6 times and threw it away each time, trying to figure out what I was going to say. And what I ended up settling on sort of comes from who I am. I moved around a lot growing up, and sort of from continent to continent, city to city, back and forth. And like one of the things that does to me is you have to learn to speak different languages. You have to learn different ways of thinking. I came to the U.S. for the first time when I was 15. I had to learn to think American. I still have trouble with it sometimes. And then before I did medical school, I was in graduate school as a basic scientist for 10 years.
Yeah, basic science.
It was in very different places in California, and it was a place where I did physics, and it was very theory-based and very not authority-based. It was a very different way of thinking. So what I figured I wanted to talk about was one of the things that's been hardest for me in doing residency and coming to medicine is learning how to think like a doctor. Because it was difficult, and it was a translation, and it still is difficult. Those of you who work with me know that there's plenty of things that I still have to work on. What I want to do is talk a little bit, and this is not emergency medicine specific, really. But this is my reflection, my understanding of what we try to do when we do, in this case, evidence-based medicine, but how we try to think as doctors and why we try to think that way. So what I'm going to do is I'm going to start with, I'm going to do a couple questions. I'm going to give you some history of evidence-based medicine. This initially was going to be a presentation that was going to be a critique of evidence-based medicine and talking about places where it fails us. And then I realized when I was going through that I didn't actually know what evidence-based medicine is. So what I want to do is try to step you through what it is, where it came from, why we think that way, what some of its limitations are, and have some of the paper lessons that I've had with being trained to think like an evidence-based doctor. So a couple of quick questions. We can just read these quickly. Just keep them in your mind, because we're going to come back to them at the end. These are from an article from 2007 that's entitled, Are you an evidence-based emergency doc? So this one is when this particular question asks about a nurse who says, don't give regular morphine, which you automatically anymore, but it used to be a thing. And you want to think about what you would do in response. If the nurse told you that he or she read something in an evidence-based nursing training. Second question is a medical question. Reducing Colles fracture, there's different kinds of blocks. Just think in the back of your head how you would sort of decide how you're going to provide local anesthesia to a patient like this. And the last question is just sort of a personal question. When was the last time you found a paper you were so excited about that you had to run out and tell another, hopefully, doctor about it? Right, so keep those in the back of your head. So I want to start with history. So this was interesting to me because imagine many of you were not born or being born in 1991. I was halfway through high school. 1991 is the first time that the term evidence-based medicine was ever used in publication. This is by this guy, Gordon Guyatt, at McMaster University, which is in Hamilton, Ontario, Canada. And he wrote a pretty provocative initial piece. He's an internist. He wrote something in the ACP journal. He gave this case. And he said, okay, so there's an internist who sees a 70-year-old who's tired. The hemoglobin's 9. So the internist decides, okay, she's going to do an investigation for iron deficiency anemia. So I realized that very few people in this room are internists. What do you do for iron deficiency anemia?
Send
iron study. So I'm sorry about the formatting, but I can tell you what this says. So the article goes on and says, the way of the past is when this internist was in training, she was taught that she was supposed to send ferritin and an iron saturation for iron studies. So she sent that and hoped that they both came back consistent. If they didn't come back consistent, they disagreed with each other, she was going to proceed either according to her own clinical instincts, ask a more senior colleague or a local hematologist, or consult a textbook. And then the next paragraph, or the next section, is the way of the future. Right? This is 1991. So Guy goes ahead and says, so now she turns to the microcomputer in her office, which has a modem and an inexpensive software linked by telephone to Medline. She conducts a quick computerized literature search, retrieves 7 citations at a cost of only 79 cents. She then faxes the citation to the library, goes the next morning to pick up 7 papers, reads through it, decides whether the diagnostic test she wants to use, transferrin and ferritin, are relevant, decides what her pretest probability is, what her post-test probability goes through, and does what we are taught to sort of do, at least in principle, in conference when we talk about assessing evidence: pre-test, assess a test, post-test. And it turns out actually that this guy was actually the hematologist, or was the internist who wrote the initial paper, sort of on the sensitivities and specificity of ferritin. And it turns out you don't need to send transferrin, because iron saturation is not at all specific or sensitive, and ferritin by itself has a much better ROC. All right, so what Guyot's argument was. It was written very sort of aggressively, saying that in the past you would do what you were taught to do, and his manifesto, their manifesto, was that you shouldn't be just doing things based on authority. This is like very obvious and secondhand, like I think to everyone in this room. But at that point, he was arguing that we did in medicine too much by authority, and we need to instead base things on critical evaluation of the evidence. So the next year, there's an EBM working group that formed out of McMaster and a couple other universities. They started the Rational Clinical Exam Series, if any of you read it in JAMA. So that started in 1992. And it was out of this working group who sort of talked about, okay, how do we actually come up with a way to formalize evidence for the things we do day to day? In 93, Ian Chalmers started the Cochrane collaboration, and David Sackett, who was Guyot's mentor, in 1996 defined evidence-based medicine as conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. The practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. So this is 1996. Over the next 10 years, in 2001, evidence-based medicine was actually listed as one of the New York Times Magazine's ideas of the year. And then this is my favorite. So in 2007, the BMJ, formerly known as the British Medical Journal, asked its readers to come up with a list of the most significant developments, medical milestones since the start of the British Medical Journal in 1840. The top 15 are shown here. So evidence-based medicine actually made it off the list in 2007 as one of the most significant changes in medical practice during the last 160 years, or in 70 years. It didn't win, the sanitation one. So Sackett and Guyot sort of sold this as, and they sold it very intentionally, very provocatively, and very, very aggressively, saying that this is a new way to do things, and that we want to break with the past. And they did it to get a rise, to get a response out of people. Obviously, there was a movement before this. People were thinking that doctors were scientists and scientific thinkers prior to this. In the 20th century, there's names you may have heard of, Chalmers and Cochrane, from the Cochrane collaboration's name. We sort of started working on reproducible studies of medicine and clinical study and clinical science, controls, doing statistics, and randomization. Even before that, sort of since the Enlightenment in Europe, in Western medicine, there's this guy, Francis Clifton, in 1732 wrote a treatise on the state of physics, ancient, modern, and ideas for improvement. His ideas for improvement, which were very novel at the time, were this table, and he would keep track of his patients. And initially, he had a column for the weather, but he decided the weather wasn't relevant. So he had this, but his principle was that he was going to have a tabular method for keeping track of what the patient's complaint was, what he did, how it turned out. And he goes through and says, you should really come up with abbreviations for words like stool, sweat, urine, heat, pain, and the like, and try Greek. So he came up with this idea of tabulating. John Hunter, who's sort of a surgeon and urologist and an ID specialist in England in the 1780s, actually was one of the first people to use placebos. He was convinced that gonorrhea and syphilis were the same thing. And he was convinced that neither of them required any treatment and they would just get better by themselves. Because apparently that's in general what gonorrhea would do. So he thought that's what syphilis would do as well. So he tried treating syphilis patients and he came up with the idea to use placebo. So he gave some people mercury, which was the standard of care at the time. And he gave other people red pills. Unbeknownst to them. And he concluded that the people got better regardless of whether he gave them mercury. So 1786, someone's thinking about controls. In the 19th century, Florence Nightingale, who actually, many people I think know was a nurse, but was actually the first woman in the Royal Statistical Society, who actually went through and started approaching these tabular controlled experiments in a statistical way, and looking at causes of mortality, looking at changes in causes of mortality, and whether or not those changes were due to chance. So this movement had sort of been building, but there was something very explicit that evidence-based medicine tried to draw a line between. So this guy, John Hunter, he actually, when he was convinced, this is sort of one example, one of the most dramatic ones, since he was convinced that syphilis and gonorrhea were the same thing, he took a swab from one of the students who had gonorrhea. Unbeknownst to him, who also had a syphilitic chancre inside his urethra, inoculated himself, and then progressed to say, look, you can get chancres from gonorrhea. This man, because he was one of the giants of infectious disease at the time, basically delayed the progress in sexually transmitted infections by 50 years, because it was 50 years before anyone actually stopped and looked at a microscope to realize that spirochetes and gonococcus are two different things. So the approach for evidence-based medicine, right, was supposed to be, when you have a patient, you want to formulate a clear clinical question from that patient's problem. Search the literature, evidence-based medicine, the initial sort of setup, describe this, this is all stuff you already know, this hierarchy of evidence, right? From expert opinions to case studies to controlled experiments all the way up to RCTs and to meta-analyses. So you would choose the best available evidence, critically evaluate it for validity and usefulness, and then implement useful findings and practice. So that's kind of hard to argue with, right? That sounds, at least I think to someone who's trained in 2016, like a pretty obvious way to approach medicine. So there was sort of this, in 1999, there was this sort of tongue-in-cheek this discussion about what else could you possibly do. And this is sort of one of my favorite responses, where they came up with all different sort of approaches. So you could have evidence-based medicine, which is basically, and I know people who are, I can think of attendings or other residents in other programs than ours, who like embody every single one of these, right? So evidence-based medicine, eloquence-based, does anyone know Sammy McFarland? Yeah. So there are people who, to the people, to Gaia and Sackett, their argument was, of course, this is how we're supposed to do this. There's no other objective way to proceed. So there was an immediate and quite significant backlash, and I think that to some extent still continues till today, right? So what are some of the things that are wrong with that? Why is there even a discussion or even an argument about whether or not we should be using evidence when we do, or studies and critical evaluation when we decide what to do?
Because that's not the way we've been doing it.
Because that's not the way we've been doing it. And can anyone think of anything else?
There's always like that random little exception, or that 1%, or that 0.25%, or that rare person, and you think you might be seeing that person in front of you.
Okay, so
you might not
so
follow the
application, absolutely. So application to individual patients is limited. And the idea is that if you're looking at a particular subgroup, or if you're looking at people with multiple comorbidities, they may not be represented in your clinical trial. So you may not be able to find a clinical trial that applies to your patient. Your patient may have, the population of the trial may have been heterogeneous, and you can't necessarily apply it to a person in front of you if you just go on aggregate results. That's not the way we've always done it. Was certainly actually, I think, and is still a significant part of the response in the backlash, is that the doctor-patient relationship is sacred, and it's a one-on-one interaction, and the doctor decides, hopefully together with the patient, what they two together want to do, and by coming up with guidelines and prescriptions and rules about what can and cannot be done, you take away the autonomy of that interaction. What else?
If the evidence is poor.
So the evidence can be poor. There are, I think one of these papers was written by a dermatologist. There are 4,000 different nosologies, different like categories within dermatology, and like you can't possibly have randomized controlled trials for every single one, right? And so you're not going to be able to answer every single question. And in the absence of evidence, what are you left with? You just say, what's that? Anything else?
I think sometimes it turns into like a cookbook, a recipe that you follow, and then the actual scenario in front of you sometimes has a lot more factors and nuance than what the cookbook may suggest.
Yeah, absolutely. So then I think some people say that it oversimplifies, it turns things into an algorithm. People aren't machines. They can't be simplified down to an algorithm. There's a couple of other, and actually, for me, coming, and I don't know, Melanie, if this applies to you, but coming from a basic science background, one of the things that was difficult is that it's hard for me to just think about making decisions based on empiricism and just on rules and just on memorizing what trial said what to. There should be a principle, there should be an understanding, there should be a pathophysiology, you should understand why it is that epinephrine works and vasopressin doesn't. Why it is we use levo and why it is that we choose not to use ADH at high doses in shock. There should be a motivation to organize your knowledge. And that's always how medicine has proceeded, that's how we've always done things. We've always tried to understand the human body and motivate clinical trials based on that. If you just go with evidence as the only and the ultimate source of decision making, you don't have an understanding of what you're doing. You just have a set of rules or a program.
I feel like you don't have a chance to change the rules ever.
Right. So there's supposed to be an understanding of physiology. You're supposed to do the clinical trials. The clinical trials don't give you the results you thought. You go back and you change the theory. And that link is broken when you just have trials. So there's a couple different responses to this. The first way to answer this is that or these concerns is some of this is just true of all of medicine, right? I mean, you mentioned that we don't have enough clinical trials, we don't have enough data to make the decisions we want to make, and that will always be the case, right? There are, I think it's over 1 million articles a year added to the PubMed database every year now, and and the number added every year goes up by another 8%, so it's exponentially increasing. So, and that's only going to continue. So we keep adding data far more rapidly than any of it can process it, but it'll still never be enough, and that's a problem of medicine, right? I think that the idea that it devalues, and this is sort of what Sally was talking about, this idea that this is not the way we've always done it. It devalues clinical expertise, and it devalues an understanding of basic science, and it promotes a cookbook approach to medicine is sort of what I want to talk about for a minute. So I'm going to just refer a little bit to some math. There's equations on here, but the point is not the equations. If you sort of remember when we talk about diagnostic testing and these 2x2 tables and all the things that Senator and Dr. Z do early at the beginning of every year, And you remember we talked about, you always have to have a pretest odds. You have to have an idea of what you think the person has, and what the chances are that the person has a PE before the test. And what the test does is it changes your probability from pretest probability to the post-test probability, right? So in the same way, and I think this is something that doesn't get talked about as much, but when you have a study, and the study says, oh, there's a p-value of 0.05 that a beer block is better than a hematite block for reduction of alcohol use fraction. So what does that mean? What is the 0.05? What is the p equals 0.05?
There's a 5% chance that your results happened just on chance.
So there's a 5% chance that your result that
The difference that you observed happened randomly as opposed to the actual difference existing.
right. So does everyone agree that means that the chances that you're going to have a false positive are 5%?
It's a chance for random.
The chances that you're going to think that there's a significant difference when there wasn't one,
Right.
when it was actually random, is 5%. Right? That's how we're supposed to interpret it. Why are p-values limited? What do we like to use instead of p-values? So there's a couple of things, right? Like just knowing that something is significant, that is statistically significant, is not actually what we as doctors care about.
Clinical significance.
So what we need to know is actually whether something's clinically significant. That's when we talk about things like the number needed to treat or the number needed to learn, right? The other thing that the p-value doesn't tell you, it actually doesn't tell you what your chances are of having a false positive. Just like in a test, just like in a D-dimer where it changes your pre-test probability to your post-test probability, it's the same thing. If you have a p of 0.05, in order to know what the chances are that that you believe a study, you have to have your same pre-test probability, what you think is going on. And based on what you think is going on, determines what the actual probability for false positive is. So, very glazed over, right? So I'm going to give a couple of examples. All right. So here's my favorite example. If your pre-test probability is 100%, if you know that something works, you don't need a randomized controlled trial, right? Similarly, if you know from first principles that something does not work, my apologies if anyone here is a big homeopath, but if you dilute something down 10 to the 50th times, and there's only 6 times 10 to the 23 molecules per whatever, it's impossible, based on everything we know about science, for that water to have any effect, any memory of what was in it. And so there's no need to do a study on whether or not, or to do a Cochrane, or not even a study, to do a meta-analysis on whether homeopathic cures can help to alleviate dementia, right? Because you know already, your pretest probability, your belief from the beginning is that there is no way for this to work. So it doesn't matter what the trial shows. And there's other things, obviously, where trials aren't even appropriate, right? It's not appropriate to do a trial for side effects of, to do a randomized trial for side effects of the MMR vaccine to see if it causes autism, because really, just given our pretest probability of how well we know this works, it would be completely unethical to take a large group of kids and say, we're just not going to give you MMR and see how many of you get autism, right? So, what we're supposed to do when we do evidence-based medicine, it's not, and maybe this is already obvious to you, and I think we do a good job of teaching here, so I think maybe it is already obvious to you. But what you're supposed to do is, what we're doing is not just learning a bunch of trials. And we're not just learning a bunch of what things are significant, what things are number needed to treat, some number needed to harm, and which one of those are have a p less than 0.05. What we do is we start with everything we have in our heads. We start with our clinical experience. we start with our intuition, we start with the knowledge of our patient population, we start with the demographics, we start with our basic science, understanding what's going on. That's our pretest probability. That's when you walk in the room and you're like, 100% CHF. That's your gestalt. That's everything you bring to the table, right? What evidence-based medicine does is it tells you how you're going to change that. So the point is that evidence can be wrong, and you need to be, and you have to have a healthy skepticism about studies that are published. Right? The fact that something is a randomized controlled trial doesn't mean that it's true. If you believe something strongly enough, if you have enough experience to begin with, then you should be skeptical about clinical trials that don't make any sense. Conversely, if there are good quality clinical trials that completely disagree with your expertise, your experience, your intuition, maybe you need to be humble about your intuition as well. Yeah.
I think that's actually a super important point that you can't stress enough. Because I get people come to me and be like, I read this randomized controlled trial that if you give heparin for a dissection, they do much better because the clots don't get to the brain. Like, it just doesn't make sense that that would happen. And you need to look at the study really closely to see like what they actually did, if their conclusion was supported by the data. I find that over and over and over again, people quote like crazy studies that you know shouldn't work. And when you go and look at them and look back at them, they're just foolish studies. You really have to be really like think about what you're saying and whether it should work or not, and really look at it.
My favorite example was one I didn't put in here, but there's entire Cochrane review on, the heparin actually probably is a more relevant example, but there's a Cochrane review on intercessory prayer, where you go and you find people in different cities and you give them names of people in your ICU, and you randomize. You say praise for these people, but don't pray for these people. And they're actually a total of about 15 studies, and 5 of them show that the people who were prayed for do better. And the meta-analysis concludes that we don't have enough evidence, but the evidence is in favor of intercessory prayer by random strangers in other cities. So you have to start with what you bring to the table. You have to understand that a trial is a trial, and that gets to what you know about medicine.
A couple years ago, Adam Alicio sent out an email on the listserv regarding a link to a study where these authors made up a completely erroneous study with horrible statistics, terrible study, just to see how many journals it would get accepted at. It was actually pretty scary. Like the success rate they had, just proving that not all studies actual valid research. You should be skeptical of everything.
Absolutely.
You said earlier that I think there's not enough data for some things. I feel like sometimes there's too much data. It's so hard, like you were saying, there's a million papers that get published every year to try to keep up and sift through what's actually not just totally a sales pitch, what's actually true, what doesn't make any sense. And I think that's also something to think about. I wish there was a better way of having some sort of filter system that takes whatever is actually true, whatever is the best evidence, and kind of, percolating that out to whoever's practicing.
Yeah, and so we do some things, right? Like you use things like Cochrane or Best Bets. Maybe you use UpToDate, which is maybe more sketchier. You use your colleagues. You talk to people you trust. You talk to people whose opinions you respect, and you learn from each other, right? Because you're right, because it's impossible to go through everything you need to know because it changes day by day. Right. So a couple of other problems that I think are real problems with what we're doing in evidence-based medicine. They're related to what you're talking about. Number one, obviously, there's bias, right? So this is a paper from Reach 1, 2010. If you look at all the papers that look at their funding sources, whether they're sponsored by industry or they're sponsored by government, and you look to see what proportion of them are successful, unsurprisingly, 85% of industry-sponsored papers show a positive outcome on the drug that they are selling, whereas it's almost half of that when you come to government-sponsored papers, right? So again, you've all been trained well on how to assess papers. You know that you actually do need to look at, even if it's not nonsense like the paper that Adam sent out, you have to also look at what the author's biases are. You have to look at who they're funded by, what their motivation is, what their goal is in getting the you also have to realize that what you see, and when you do a meta-analysis, and you're like, well, I have this meta-analysis from Cochrane, they gathered all this information together, and they must have looked at everything that mattered. You have to understand that what's out there is not everything that there is, right? So if you look, this is specifically for psychiatric medications, and it was after, there was a series of papers published over the course of 2 years that showed that risperidone is better than olanzapine. Olanzapine is better than paroxetine, but paroxetine is better than risperidone. Like, they're just papers that show that everything's better than everything else. And part of the reason is that you don't get, if you look to see whether papers are published, obviously we don't tend to publish negative results. We don't tend to publish replications that are duplicates of confirmatory studies. So we see these groundbreaking new non-inferiority of my new drug that costs 10,000 times more. And we don't see the multiple other smaller trials that didn't show any effect. So when we do a meta-analysis, we're missing a lot of data. So bias is a real problem. Another issue with evidence-based medicine is something near and dear to my own heart, is that you have to understand that the priorities are not set by the need, right? So this is DALY, disability adjusted life years, is basically a measure of how much each of these diseases affects humanity. On this axis, on this side, the number of clinical trials that were published, I think, in 2014 over the course of 1 year. So there was only one clinical trial in leprosy. It turns out, not such a huge worldwide problem. Probably okay. For per disability adjusted life year, for infertility, there were between 2 to 25 RCTs for infertility, despite the fact that it's not, although it's certainly significant, it's not a scourge of humanity, right? If you look at malaria, actually, there are more randomized controlled trials, right? How many people, like 200,000 people die every year of malaria? 10 million infected? There were 10 randomized controlled trials per disability adjusted life year of malaria. So obviously, like when we look at the evidence is skewed not based only just on bias, but also on what trials we choose to conduct. Moreover, the people who participate in these trials are not necessarily obviously representative of the people that we here are trying to help, nor are they necessarily representative of the kind of people we as doctors want to help in general. They're very specific. We don't necessarily get information on the patient populations we care about and on the patient populations with the greatest burden of disease. And clinical trials, again, because of where the money is, are heavily, heavily, heavily skewed towards drug interventions. So on the right, registered commercial trials, if you look in blue, those are commercial trials, this was 2014 also, that were registered, who were trying to assess the non-inferiority or efficacy of a drug, a vaccine, or a biological. So something you can inject, preferably something you could inject multiple times, or you could give multiple times. As opposed to the pink, which is surgical or other interventions, and green, which is psychological interventions, education, training, diet, preventative care. So because diet changes don't make money, there are very, very few. There are 74 clinical trials registered there, as opposed to 689 registered for biologics. So again, there's a big bias in the choice of what we choose to study. So wrapping up, there's a couple other things just to be aware of. Science isn't perfect, statistics are statistics. There's this sort of famous paper, if you ever get a chance, and if you care about this sort of thing, it's a very interesting read, called Why Over 50% of Published Studies Are Bullshit. Or it's not actually bullshit, it says something else, but or incorrect. By this guy out at Stanford, and he goes through and here it comes up with a list of studies that are extremely highly cited, so that have over 1,000 citations in the literature, who had large numbers of participants, so anywhere from overall, depending on how you count these, from thousands to hundreds of thousands, to tens of thousands, that were either contradicted later on, or later in replications or in larger population evaluations shown to have a much smaller effect than was initially predicted in the landmark study. Right? So you have to take your evidence with a grain of salt, and again with some humility. Because things change, science changes. The world isn't flat. And then sort of the last one, which is again near and dear to my heart, sort of my favorite one, This is sort of, I'm going to be an IT fellow, right? So this is like a really, really famous thing. Does anyone have any idea what this is? I didn't like it intentionally. So this is 1990. That is, you take a group of people, you split them in half, and you give one half, not quite hard. So you give half of them AZT, and you give the other half nothing, and you see how many of them die. And when you look, over 2 years, dire progressed AIDS, over 2 years, there's a number needed to treat of about 15 people on AZT alone. And the initial studies, and for those of you who were alive in the 1990s, the initial studies sort of said this is not, we don't know what's going to happen after 24 months, we don't know that this is going to be a sustained intervention, we don't know what all the toxicities long-term of AZT are. And there was this enormous conflict between the NIH and the NIAID and clinical scientists and people here in New York, for instance, who were dying of AIDS by the thousands in certain populations, right? Who are saying that we don't give a shit if it doesn't work. Or we don't care if we don't have pure studies, we don't care if we don't have extended durations, we're dying anyway, right? And then sort of this, so what Sally mentioned is that this is not hard, this is AZT. The other thing to remember is that clinical trials, at least the way we do them, don't always come up with complex cures or complex solutions, right? To understand, to get to heart, you had to try multiple drugs together before we realized a combination therapy that worked. The individual drugs by themselves, clinical trials were very ambiguous. So you needed an understanding of the physiology and how HIV works in order to come up with something like heart. All right. So I want to try to bring this a little bit more concrete, and just try to explain why I want to talk about this. So we started with this, right? So I asked you a couple of questions early on. The first question was this nurse who said, "Did you really want to give Reglan with morphine?" So I don't know. Does anyone know? Does anyone do that? Did anyone used to do that? Apparently, so I didn't realize it. Apparently this was very, very common, it was routine. In the early 1990s, there was a series of studies showing that there's absolutely no benefit, and if the person's already nauseous, giving Reglan doesn't prevent or reduce nausea. Right. So that's sort of the medical answer. The reason I asked the question was I think that when you do what we do, and you get really excited about studies showing the value of CTA and ruling out some arachnoid. You talk about all these things in conference, you get excited about different ways to do things. Please come to work every day with some humility, right? So remember that evidence-based medicine and the way we talk, and what's the TIMI score and the heart score, and what's the pretest probability, and these are ways. They're not absolute answers. They're ways of communicating. They're ways of persuading. They're ways of speaking with our colleagues and with our patients and with each other, right? They're not hard and fast rules. They take what we believe and they try to move them. Always keep questioning yourselves, question your attendings, question your juniors, and just realize that evidence is fluid and it's imperfect. And even large trials, even high-profile trials, could change next year. It doesn't mean you can't be paralyzed. You still have to do what you can with what you have. We make the best we can. We make the best choices we can under our uncertainty. But you realize that you could be wrong, right? So the next question was this question that I sort of asked you to think about, like, would you do one thing or the other? And there's again some evidence based on that. The reason I was sort of asking that question is that the other thing that I realized that I care about is be compassionate towards your patients. Recognize that evidence suggests options, provides possibilities. At the end of the day, you have to take your patient population, your clinical environment, right? Doing a beer block ties you up for 20 to 30 minutes at the very least. And your patient's preferences and your experience. You have to take all these things into account. It's not enough just to say, the study says use ketofol, so let's use ketofol. You have to come up with your options, and you have to do shit. You have to try to make shared decision making and joint decisions with your patients. Remember, your patients are people that they have preferences about whether or not they're willing to take the risk that a statin is going to give them a myopathy, or whether or not they're willing to take the risk that they want to go home. They don't want to spend the night in the hospital under observation for chest pain. Remember that we all have this acceptable miss rate, but all the numbers we talk about are guides to how we behave. Your acceptable miss rate may not be your attendings. This is sometimes very frustrating, I think, for junior residents. You realize that one attending will practice one way and another will practice another way. It's not, even though they're working from the same basis of evidence, and it's because people have different tolerances, so that's okay. That's part of being a doctor, right? Is you come up with your own tolerances for risk and your own tolerances for what you and your patients are willing to accept. And then the last sort of thing was this question of when's the last time you found a baby you were so excited about you ran out and told someone. How many people here have done that sometime in the last month?
Well, then that's
So April was a slow month, but in April I counted 9 times on the EM listserv that somebody sent out a paper saying, hey, look at this is practice changing, or look at this is the best explanation of this I've ever heard, right? So the last sort of message I have that I've taken away from the last 7 years is be proud of what you do, right? You need to come to work with humility, you need to come to work with compassion for your patients, but realize that you're well trained, that this place is incredibly frustrating, and it's a hard job, and pod A at 4 o'clock on a Monday can be a nightmare. But what you get to do every day, and the kinds of decisions you get to think about, are incredible. And it's a privilege. And it's a front seat to the most incredible human show on earth that you couldn't buy tickets for. Right? You work at a county hospital in central Brooklyn, the only academic center in Brooklyn that does studies, that tries to bring studies to this population, that serves a group of people who wouldn't otherwise necessarily have access to healthcare. So when you get frustrated by your ancillary staff not moving as quickly as you would like, or not being able to have the neurosurgical procedures that you wish you could offer, you remember that you're working in an environment with limited resources, and you do a pretty good job most of the time. And then sort of the last thing is something that the last time Chris Doty, who was my program director, our program director when we started, sort of ended the last time he was there, he sort of ended this conversation, like, especially for those of you who are graduating. This is a pretty incredible place. And again, it's frustrating, but the people you work with can deal with anything, do deal with anything, right? The 4 trauma codes back to back to go back at 6:55 that you just take in stride. And you just sign out to the person who comes in at 7:01 because you trust them with your patients' lives. So what Doty sort of said at the end of his talks was, just remember when you leave here, the 2454601 is CCT again, like it's a county doc every single time. And he said that 10 years out, he still calls the county sometimes just to ask a question. So this is my initial EM class. Those people in particular, people who, I mean, these are all wonderful people. Those are people who I've been with for 5 years. I think the rest of my thank yous like erased, but that's it.